Good evening, everyone. Welcome to master classes from Yashoda Hospital in association with ISCCM Hyderabad chapter. Today's case for discussion is calcium channel blocker overdose. To take this case, we have two senior consultants, Dr. Dedeepiya Devaprasad from Apollo Hospitals, Chennai, and another senior consultant, Dr. Sanjith Saseedharan from Mumbai. To present the case, we have two students from Yashoda Hospital, Dr. Rohita and Dr. Ruhi. They will be presenting the case. Sanjith sir, you can take the case.
Okay. Just for my knowledge, I can stop anytime and ask them a question from the slide.
Yes, sir.
All right.
Good evening, sir.
Good evening.
Today my topic of discussion is CCB poisoning. I'm Dr. Ruhi from Yashoda Hospital. I'm Dr. Rohita, sir, Yashoda Hospital, Somajiguda, sir.
Hey.
There was a case of 23-year-old female, nursing staff by occupation, was brought to ER with alleged history of consumption of 25 tablets of 10 mg of tablet clinidipine, and the total dose of 250 mg at 7 p.m. at a residence. She had complained of nausea, giddiness, and fall. Duration between the incident and hospital admission was around 1.5 hours. There was no history of any chest pain, palpitation, dyspnea, cough, loss of consciousness, and seizures. No prior comorbidities, no history of any co-ingestions, no previous history of any suicidal attempts, no history of any psychiatric illness, no history of drug abuse, and no history of any prior hospital admissions. On arrival to ER, her GCS was 15/15, and vitals, heart rate was around 140, BP was around 80/50, saturation 98% room air, respiratory rate around 22, and GRBS 107. On examination, CVS normal S1, S2 was heard, and respiratory system bilateral normal vesicular breath sounds, and per abdomen was soft and non-tender.
Rohita, why do you feel, let's go back to the slide again. And why do you feel that blood pressure is on the lower side, and why do you feel that the heart rate is fast? What do you think the reason is?
Basically, sir, it is which acts on vasculature. This amyloid, whichever clinidipine which has taken, it is a non-dihydropyridine.
Clinidipine is a
dihydropyridine, sir, dihydropyridine, which acts usually mostly on peripheral vasculature, which results in mostly vasodilatation, and also which results in reflex tachycardia. So that
but is this the scene when you give this kind of dose? Because what I'm seeing is 25 tablets, which is quite high. So when you have such high doses, does it cause vasodilatory shock with reflex tachycardia? Because a lower dose, I think, will probably follow what you're saying. But at higher doses, it will probably lose selectivity for its vasculature, right?
Yes, sir.
So this is a very high dose. So in such a high dose, don't you think that this will also cause combined bradycardia?
Usually, in a higher dose, it will lose its specificity, so it will also act on myocardium. I mean, not on specificity.
Absolutely. So such a high dose that you gave, 25, is definitely a high dose. 25 tablets cannot be a lower dose. So do you think that there is co-ingestion of anything further? Because you're having tachycardia here.
Yes. We had the same doubts, and we had further inquired about it, but as she was a nurse by profession and she was very confidently, like, her history was that she had taken only clinidipine. So
okay, so what happens if you had a situation where your blood pressure is low and your heart rate is low? What are your differential diagnoses in a case of poisoning?
Usually calcium channel blocker toxicity, beta blocker toxicity, and digitalis.
Right. So how do you differentiate? Say you have a patient who's taken calcium channel blocker and beta blocker, or you don't know whether it's calcium channel or beta blocker, because what I'm assuming is this patient has got some kind of hypotensive agent that patient has taken, and both the drugs have been taken, and you want to differentiate between calcium channel blocker and beta blocker toxicity. How will you do that?
Usually in glucose levels, sir. Usually hyperglycemia will be there in calcium channel blocker toxicity, and hypo in beta blocker toxicity.
Why is that so? Why is that so? Why does a beta blocker cause this kind of a situation, and why calcium channel blocker shows hyperglycemia? Why do you think that might be happening?
Calcium is required for the pancreatic beta cells to release insulin, sir, because the calcium is not present. So because of the hypoinsulinemia, there will be hyperglycemia, sir.
Perfect. So that's the entire cause. So where else will this calcium work, you mean to say? This, you did say that it's going to work on the pancreatic islet cells.
Pancreatic islet cells, yes, sir.
Where else is it going to work?
Vascular smooth muscle, sir, myocardium, the conduction system, and pancreatic beta cells, sir.
So we go back to the same question. So vascular smooth muscle is the first thing that will probably work when it comes to dihydropyridine channels, and the myocardium comes later on, isn't it?
Yes, sir. Yes, sir.
Okay, so why is that important for you to understand? So that means, how will you differentiate? So is there some kind of investigation that will help you to lower down your diagnosis again, apart from sugar? So you just gave the answer, myocardial
ECG.
yeah. So a 2D echo, no? A 2D echo will give you a myocardium. It will probably tell you the answer that there's myocardial depression happening, and that means it's either high dose or it is related to some kind of non-hydro dihydropyridine calcium channel blocker like verapamil or diltiazem. So what's the difference between diltiazem and nimodipine or amlodipine? What is the difference between both of them with respect to the clinical features that you've mentioned?
Sir, non-dihydropyridines will specifically, they have more specificity towards the conduction system of the heart. So they will be presenting with bradyarrhythmias, sir.
So verapamil will cause more bradycardia or more myocardial suppression?
Myocardial
suppression and causing also bradyarrhythmias, sir.
So it's the other way around, no? So it's the non-dihydropyridine calcium channel blockers will actually cause the patient to have myocardial suppression, isn't it?
Yes, sir.
It's the other way around. And so early development of hypotension and bradycardia, isn't it? That's how that will probably what is going to happen. All right, let's go ahead.
In her investigation, her ECG showed sinus tachycardia with QTC of 430 milliseconds, and PR interval was normal, sir. Yeah.
So what do you expect otherwise? If you actually have microdose poisoning, apart from QTC prolonging, so what would you probably see in calcium channel toxicity, calcium channel blocker
Usually
toxicity?
PR interval will be prolonged, sir.
Yeah. So you will have a heart block, isn't it?
Heart block, like because it acts on AV node, so that is why the PR interval will be prolonged.
And what about if you look at beta blocker toxicity, what will probably come there?
Hello.
So Devaprasad has joined.
Yeah. Can you hear me? Sorry.
Yes, sir, we can hear you.
Yes.
Okay.
Hi, Dr. Sanjith here.
Hi, Dr. Sanjith. I was always
both of you
hearing
can
this.
switch off your cameras, sir. Sanjith and
Okay. Yeah.
So that will give them a exam feel.
Okay. Switch on or switch off?
Switch on.
Sir,
Switch on.
Devaprasad sir can't switch on the camera. He's not able to move to panel due to some error.
Yeah,
Okay.
it shows me join as panelist from the first time, but
But there is some error is coming, sir, in between us.
Okay, please go ahead.
okay. Yeah. So you did talk about ECG changes sinus tachycardia, right? Hello?
Yes. Hello.
Okay then. Yeah, please continue.
So my question was, if you have beta blockade poisoning versus calcium channel blocking poisoning, what would be the difference, or do you see something further in the ECG for beta blocker poisoning as compared to calcium channel blocker? What would you see? You'll probably see a QRS widening, isn't it? Maybe you'll see a QRS widening, you'll see a tall R wave in the AVR, you'll see a Brugada pattern. These are things that you'll probably see on top of the calcium channel blocker. So I did see the number of labs that you have sent. Okay. do you want to send something more in this? I mean, I see you sent an ABG, you have sent a urea, creatinine, sodium, potassium. What else you want to send here?
Calcium,
Very good.
Calcium levels, sir.
calcium
basically.
levels.
Calcium, anything else?
2D echo, sir.
2D echo. And what else can cause these kind of manifestations? Any other electrolyte imbalance, to be precise?
Magnesium.
Magnesium, very good. Magnesium, absolutely, and phosphorus.
Phos-
Right. And what about any hormonal things that can cause this kind of a situation? Is there anything that can cause something like this, tachycardia? This patient not doing well. Any hormonal problem that can come in, which causes this kind of reflex tachycardia, or maybe sometimes atrial fibrillation also. Anything that, yeah. TSH.
Hyperthyroidism.
Yeah, so that's something also you'd probably want to send. Yeah, let's go ahead. Anything about the blood gas? You are okay with this blood gas? Is this blood gas normal?
Has a respiratory alkalosis, sir, with pH of 7.5 and PCO2 22 and bicarb was 20, compensated metabolic. Or it was respiratory alkalosis with compensation, sir.
So what is the primary disorder here?
Respiratory alkalosis, sir.
Okay. I would call it metabolic alkalosis.
Metabolic acidosis with compensated respiratory alkalosis.
Respiratory, yes. Yeah, okay. And the lactates, what kind of units is this? 2.6?
Millimoles per liter.
Okay. Yeah. All right. Let's go ahead.
Serum calcium was 10.2, sir. And after taking consent, we have done her UPT test, which was negative. And echo was normal with EF of 62%.
Yeah.
This was our ECG, sir, which showed sinus tachycardia.
It's clear sinus tachycardia. Let's go ahead.
And,
Okay. Can I just ask you, what is the ECG changes that you otherwise expect in calcium channel blocker poisoning?
PR interval prolongation, sir.
Okay.
bradyarrhythmias.
Bradyarrhythmias.
Okay. Then?
AV blocks.
AV blocks. Okay. Okay. Okay then. Anything else other than that? Yes, bradycardia, yes. AV blocks. Anything else? Okay, continue, please.
Treatment gastric lavage was done, sir, and activated charcoal 1 gram per kg RT stat, and IV fluids was started, and as normal saline 1 liter bolus followed by 100 ml per hour. IV pantoprazole 40 mg stat and IV ondansetron 4 mg stat was given, and injection calcium gluconate 1.5 gram IV stat over 20 minutes, and 25% dextrose 200 ml IV stat was given, and human actrapid 0.5 units per kg per hour, and noradrenaline 2 ml per hour, that was 0.2 mics per kg per minute was started.
So you did
Okay.
a gastric lavage, isn't it?
Yes, sir.
All right. So how did you do this? How was it done?
Sir, with 16 French nasogastric tube we have introduced, we have placed, sir, and after that in Trendelenburg position, left lateral decubitus, we have done gastric lavage, sir.
How do you do that?
And 250
How much fluid do you given?
250 ml of fluid we give, sir, and then we aspirate it, sir, until clear fluid comes.
So do you aspirate or do you some drain it?
Drain.
suction it.
Suction it.
Ideally, you're supposed to some drain it, no? It is a gastric lavage is done not by aspirating. In fact, you put it inside and then you lower the tube so that it some drains. It is supposed to be sub-drained. Okay, some SUMP, some drain. Okay, that's how you do a gastric lavage. And what about activated charcoal? You think this works in these cases? When does it work?
Sir, this activated charcoal is inert non-toxic substance, sir, which has the surface area of the activated charcoal will be more, so that there will be a gradient between the blood and the gut, sir. So
Blood and gut. Blood and gut. How is the gradient here? Blood and gut, or is it something else?
between the gut and the, between the drug and the
Yeah.
gut.
charcoal.
So how do you decide the dose of activated charcoal?
It is 1 gram per kg, sir.
So
And
what
the
now?
maximum
But
dose-
here you know the dose of the drug. No? Here you know it is 25 tablets.
Yes,
If
sir.
you know the dose of the drug, then what is the dose of charcoal?
The maximum dose will give, sir.
No, if you know the dose of the drug, when you say 1 gram per kilogram, this is something that you don't know, so you're giving 1 gram a kilogram. Okay. Now, you know the dose here, this is 25. So what is actually the proportion of charcoal you're supposed to give when you know the dose?
10:1.
Very
sir.
good, very
10
good. It is 10:1.
10
How do you
1.
give activated charcoal?
So rice too.
How?
This
The powder will take the powder according to the dose, sir. That will.
What is the
mix
name of the product? When you have given activated charcoal, so you should know the name of the tablet, isn't it? Or for that matter, do you get it as a powder where you work?
Sir, in this patient, it was given as a powder in the ER, sir.
Powder. How did you get this powder? From where did you buy this powder?
They bought.
Okay, so in which patients you would not give activated charcoal?
In corrosive poisoning, sir, hydrocarbon poisoning.
Is it known to work?
And also,
What kind of benefits you get with an activated charcoal? Does it do anything to the hard outcomes? Like mortality, morbidity, length of hospital stay? What benefit does it have? I'm asking you something like that.
it decreases the absorbed dose of the toxic agent, sir.
And any benefits with respect to mortality, morbidity, length of stay, not of intubation, mechanical ventilation not being done, avoids drowsiness, anything like that? Do you know that whether it works? Is there evidence to say that this activated charcoal works?
It works if it is given the earliest, sir, usually within 1 to 2 hours of ingestion of the drug.
You're right. So within 1 to 2 hours, if we give charcoal, it is supposed to exert a beneficial effect.
Yes.
In what way? In only absorbing the toxin, nothing more than that. It doesn't do anything with respect to length of stay, mortality, morbidity. So now that you have activated charcoal, have you heard of something called multi-dose activated charcoal?
Yes, sir. In sustained release, drugs will give a multi
1 or 2 hours and 4 hours we will be administering charcoal and as a dialysis like
So any antihypertensive calcium channel blocker that you would probably give even if it is not sustained release through activated charcoal after some 2 hours also, multi-dose, any drug that you know of? Some very common drug that is generally used. Amlodipine?
No, amlodipine.
Amlodipine is something you'll probably use. So is there a role of multi-dose activated charcoal now? Is there any role?
No, sir.
So what if there's mega dose poisoning and patient has come within 1 hour? What else you can offer this patient as manual removal? This patient has come with mega dose within 1 hour, isn't it?
Whole bowel irrigation.
Excellent. Yeah. So how do you do that?
we'll
We'll give a
polyethylene
polyethylene
glycol, sir.
2 liters per hour through the nasogastric tube, sir, and then we'll by colonoscopy we can remove the fluid, sir, until the rectal effluent is clear.
So how do you know? Now see, let me explain what you have done. You have done gastric lavage, you have done activated charcoal, and now you're giving polyethylene glycol, isn't it? You're giving peg leg, right? 1.5 to 2 liters an hour. How do you know that your poison has come out? Because you're giving it 1.5 liters an hour, no? You're giving 1.5 liter an hour. So how do you know that your poison has come off? Any clue that tells you? Because you just can't keep giving 1.5 to 2 liters an hour. If you keep giving 2 liters per hour, there can be problems of aspiration, vomiting.
You can see
It's
the
peg leg.
ABG, sir, lactate.
No. No. How do you know? So what have you given? You first done gastric lavage. Then what is the next thing you have given?
Activated
Activated
charcoal.
Charcoal. And then what are you giving?
Simultaneously, we started
Peg leg.
IV fluid.
And you get peg leg.
Peg leg,
No?
peg leg,
So
yes.
now if you give peg leg, if your charcoal comes out, isn't that kind of an indication that the poison has come off? You know, the amount of time has come off. Isn't it?
Sir, if we are giving charcoal, then after 2 hours, we have to.
Yeah. So if the effluent is clear, I mean, if things that are coming
Things
out
are
from
clear.
down is clear, yeah, that means the charcoal is washed out, isn't it? Charcoal otherwise will not get absorbed. It is going to come out as a slurry black, isn't it?
Yes, sir.
So if that comes out and then the effluent becomes clear, then you are certain that most probably you could say that there's a passage of the toxin, most of the toxin outside. Can we say that? We can say that, right?
Yes.
Okay. So when would you want to intubate this patient? Do you need to intubate this patient because patient has got respiratory alkalosis, she's breathing fast, she's tachycardic, 150, blood pressure is 80 systolic, and you know, I just see that you have given activated charcoal, though she's fully conscious, but there's a chance of her hypotensive becoming and then problems occurring. So when would you probably want to intubate?
When her sensorium worsens and if there is persistent hemodynamic instability, then we would like to go for intubation.
So this patient has got a blood pressure of 80. This patient has got a reflex tachycardia. How are you going to intubate this patient? Say in the event that the patient starts going down, what are the drugs you'll use and how will you intubate and how will you take care of this patient?
We'll use cardiostable drugs, sir. Etomidate.
Etomidate. But how do you prevent? See, this patient is what do you do simultaneously? Good, you'll use etomidate. What else?
Rapid sequence induction.
Rapid sequence induction.
Okay. And what will you give on the background? Because you give etomidate or you intubate, you need to give something peripherally, isn't it?
Fentanyl.
So you give fentanyl and drop the blood pressure tremendously and patient might just collapse, isn't it? So what do you do to prevent this? You're right. You have to give, if you want to give rapid sequence intubation, you have to give fentanyl, you have to give etomidate, you have to do these things. But simultaneously, how do you prevent the blood pressure dropping? Because blood pressure is already 80, no?
We'll start
on the background to 80.
On vasopressors, we can start already.
Yeah. So you'd want to do two things. One is vasopressor and the other you said there is peripheral vasodilatation, no? What do you want to give?
Noradrenaline.
Sorry? NORAD, yeah. So you want to give noradrenaline, you want to give and you want to give a very big bolus of fluid. Isn't it? Why you want to give fluid? Because he's completely vasodilated, no? So there is space. So you'll fill that space up with fluid, isn't it?
Yes.
So you'll give fluid. So the intubation here is a bit different, no? Compared to otherwise.
Yes, sir.
The intubation here is a bit different as compared to otherwise. Yeah, go ahead.
Okay, just staying on an activated charcoal. Beyond what time is activated charcoal completely useless? Hello?
4 hours, sir.
Hello? Is it 4 hours?
Actually,
it
it
has
has beneficial effect
1 to
within
2
1 to 2 hours, sir. But because in multi-dose activated charcoal, we can use it up to 4 hours.
Single dose activated charcoal. Best effect less than 2 hours. Beyond 6 hours, no effect. Between 2 to 6 hours, questionable effect. So you have given it 1.5 hours. So do you expect to have good effect? Maybe. Yes. Okay. What are the problems of gastric lavage? Is it routinely recommended in these patients?
Based on the sensorium and ability to maintain the protective reflexes, we can go, sir.
Within 1 hour, if the patient has come, 1 to 2 hours, better. Like, unless if
okay, would you do gastric lavage first and followed by activated charcoal, or will you do activated charcoal first and then decide?
First
Generally,
gastric
what's
lavage, sir,
recommended?
then later activated charcoal.
Are you sure that is that the way in which we proceed, or? Okay, what are the problems of gastric lavage? One you said was
risk of aspiration.
Aspiration is there, sir.
Okay.
Fluid.
Electrolyte imbalance.
Okay, it's always questionable. The role of gastric lavage is always questionable. Activated charcoal that you said and we've already discussed about multi-dose activated chapel. I'm interested to know that you have chosen IV fluid and a liter of normal saline followed by 100 ml per hour. How did you choose the choice of your fluid? What influenced the choice of your fluid here? And why did you choose to use normal saline?
So 20 ml per kg we have they have given, sir, in the ER.
Okay. Why not some other drug? Why not RL? Why not? I'm just asking you. No, I'm just asking you. Do you randomly
use
choose?
RL or plasmolite also, sir.
Okay. Anything that it contains that makes you worried?
Lactates.
Okay. Does RL contain calcium?
Calcium.
Calcium. It contains calcium, sir.
Okay. So, I mean, anything that influenced you to choose normal saline? I'm just looking at it because 1 liter bolus is fine. 100 ml per hour. For how long did you continue this 100 ml per hour?
Sir, after shifting to AMCU, we changed it to 75 ml per hour, sir.
Okay. Okay, then fine. So you just decided to give normal saline and then continue to use normal saline. Fine. Any other drug, any other crystalloid can also have been given in this patient.
In AMCU, we have given RL, sir. RL and plasmolite alternatively 75 ml per hour, sir.
Just concerned beyond 1.5 liters of normal saline, just concerned about
hyperchloremic metabolic.
Nothing else. Nothing else. Okay, fine. Okay. Yeah, continue. You're given pantoprazole 40 milligram IV stat. Why did you give pantoprazole?
She's having basically she was complaining of nausea and epigastric pains. So we had given pantoprazole and ondansetron.
Routine. So this is more of a treatment for nausea and epigastric pain, which you presumed is acidity. Okay. What are the indications of pantoprazole used routinely in the ICU?
Stress ulcer prophylaxis.
For whom?
In critically ill patients, we'll give, sir.
Whom? For whom? All critically ill patients? Any particular patient?
With history of gastritis, GERD.
No.
Is it for patients who are mechanically ventilated for more than 48 hours? Could it be because the patient was coagulopathy, defined as a low platelet, less than a lakh, and coagulopathy? Okay, these are, like, I understand you're not giving it as prophylaxis, you're giving it as treatment because of epigastric pain. Fine. Ondansetron 4 milligram you're given.
And therapeutic steroids.
And then, okay. And calcium
gluconate 1.5 grams IV stat was given, sir, over 20 minutes.
What's the rationale of giving this calcium gluconate?
Because calcium channel blocker, it usually it blocks the channels. So calcium gluconate, it acts like competitive inhibition, helps in competitive inhibition. So as to increase the contractility and in basic. Increase the intracellular calcium, basically, to increase your increase contractility and
Okay, is there a role when the calcium is normal? In fact, your calcium is on the higher side, I thought, no, 10.8.
Yes, sir.
I think your lab is 8.5 to 10.5, no?
Yes, sir.
Okay. So is there a role when calcium is normal? Is there a role when calcium is high?
Sir, in these patients, we'll maintain calcium levels around 11 to 13. Sir.
Okay.
Because calcium, the receptors are blocked, so basically to keep it at high.
Are you very certain that the recommended calcium level has been recommended 11 to 13? You seem to say that. Is there any evidence or it's a practice? Hey, come on, you're doing well. Just I'm asking you. Is it based on any practice, or I think I understand the logic, but I'm just saying, is that logic supported by evidence that you want to keep a higher calcium 11 to 13 that you said, which is hypercalcemia? Is that sort of backed by evidence, or it's your gut feeling?
Evidence is
Sure, there is evidence, is it?
there's
Okay.
So is this dose adequate? Is this dose of calcium adequate? I mean, you've said 1.5 grams IV stat over 20 minutes. I mean, this patient has got a blood pressure of 80. This patient's reflex tachycardia is going on, and your calcium gluconate dose is 1.5 grams. Is that dose adequate, or is it as per what the guidelines do mention for calcium channel blocker poisoned adults?
Sir, for calcium gluconate, it is 0.22. Initially, we'll give for calcium gluconate, it is 30 to 60 ml, sir.
So if it is 30 to 60 ml, how much grams is that? You're right, it is 30 to 60 ml.
60 ml.
So when I say 10% calcium gluconate,
3 to
how
6
much
grams, sir. 3 to 6 grams.
It is 3 grams. So what you have given over here is 1.5 grams, which is half the dose. You know, when you talk of calcium chloride, you could probably talk 1.5 grams.
10 to 20.
You could call up 1.5 grams as calcium chloride.
Chloride.
But when it's calcium gluconate, you would probably want to give a higher dose, isn't it? So your
Yes,
dose
sir.
is actually not right. Also, is this the way you give it over 20 minutes? Because if you give over 20 minutes, by this time, this patient will actually go down, reflex tachycardia, hypotensive, and myocardial depression will start off. This patient has come in a toxidrome to you.
Yes, sir.
So how quickly would you want to give it? You only said that I want the calcium to be high. So how quickly would you give it? 20 minutes is a rather long period, I felt. Because if you give it over 20 minutes, when will you repeat it? How would you repeat it? And why would you repeat it? You're just given 1.5 grams IV stat. Is that enough?
No, sir. No, sir.
Then how will you decide to give more?
Sir, initially we'll give 30 to 60 ml over 5 minutes, sir, and we'll wait for the effect for the next 20 minutes and then repeat the dose again, sir. We can repeat the bolus up to 3 doses, sir, and then if there is no effect, then we can start on infusion also, sir. If it is
So then
calcium,
why have you mentioned over here 1.5 grams? If that is the case, then why should you mention here 1.5 grams? If you know it so well, you shouldn't have mentioned here 1.5 grams, isn't it? And that also over 20 minutes. Why is that so? Because what you said just now is the right answer, giving it over 5 minutes and then wait for 10 to 20 minutes. And then probably based on what you want to give the second dose. Say, for example, now, okay, I take your point that you want to give it as 30 ml, for example. You give it over 5 minutes. What could occur if you give it over 5 minutes? Okay, okay, I decided to give
hypotension would improve
Better.
So what could improve? So one is hypotension, which could improve. It will not improve so quickly. What will improve better?
Your
What will improve better? See here, no, you are already, this patient is already, you have started the patient on noradrenaline.
vasopressin.
Okay, now the blood pressure has come to near about say 90, 100. Okay, how do you notice that you need to give the second dose of calcium gluconate, or is there any way you can figure out whether I need the second dose of calcium gluconate or I want to start an infusion?
We'll see the ionized calcium levels, sir.
That is going to take its time. Ionized calcium levels is not something you just now said that I want to keep it on the higher side and all these things. So any which ways you want to give more. Ionized 10 cc of calcium gluconate is not, 30 cc of calcium gluconate is not going to get your ionized calcium to alarmingly high levels. So what do you look at? I mean, there is an investigation that you can do to understand that I need the second dose of calcium gluconate. And what is that investigation? What happens with the calcium channel blocker overdose? What happens? Apart from hypotension, what is happening to the heart?
The contractility will be decreased.
So now your blood pressure has been augmented with your vasopressor. What will improve when you give calcium gluconate?
Myocardial
My
Contractility.
contractility.
Isn't it? So there is one way you can actually figure out.
2D
Contractility.
echo.
2D echo, we can see the
Yeah,
contractility.
2D echo, 2D echo. That's how you probably want to do it. Okay. So I don't know from where you got this 1.5 grams, because that's totally wrong. If you've given this to your patient, it's not the right way to do this. All right.
Okay, sir. Okay.
Yeah. And what if you want to give calcium chloride? Is there a problem in giving calcium chloride? And if you want to give calcium, how do I do it?
We have to give through the
Through
central line,
lines,
sir.
because
Very good. Very good.
Yeah. Okay. All right. Next. Yeah. Let's go ahead. And what is this you have given? You have given actually this patient. Why is this actrapid at such a high dose?
So, because of hypotension, sir. We have started on in the ER. They have started on human actrapid, sir, 0.5 units per kg per hour, sir, and dextrose.
Why?
Usually,
Why?
Because,
at a higher dose will act as a positive inotropic
inotropic effect.
agent. So it will increase your.
So then why don't you use it for all our agents in sepsis?
So, actually, in calcium channel blocker poisoning, usually the myocardium that energy substrate is fatty acid, sir, which will be shifted during the stressed
glucose.
state. It will be shifted towards carbohydrate fuel, sir. In calcium channel blocker poisoning, because of hypoinsulinemia, the glucose won't be available, sir. So by starting this insulin, the intracellular glucose transport will be improved, sir, and also there will be coronary and vasodilatation, and it has positive inotropic effect also, sir.
Yeah.
Okay.
Anything further you can tell me? You have told it absolutely fine as to what all you can do, expect with a hyperinsulinemic therapy that you talked about. Is there something more with respect to the lactates here? Is there something more with the lactate? That's why the AVG didn't have lactate. So I was a bit worried why there was no lactate there. So it causes an increase in the uptake of glucose and lactate, no?
Yes, sir.
And how does that do that?
Anaerobic glycolysis.
No. It increases pyruvate dehydrogenase activity, no? This is what it does.
Okay, sir.
Okay. So all this together, what does it do? It actually improves the myocardial contraction. isn't it?
Contractility.
Okay. So is this the therapy you're going to give first, or is this therapy going to give, when will you decide to give this therapy also? Is it the first line? Is it the second line? Or you will give it in all patients? How is it? How do you decide that?
Sir, initially we'll see for airway breathing and circulation, sir. If if the patient is having hypotension, we'll initially resuscitate with fluids and start on vasopressors. But in this calcium channel blocker toxicity, the specific first line therapy is insulin, calcium salts, then insulin, hyperinsulinemic euglycemic therapy, sir.
But this patient, say for example, you have a patient who comes with calcium channel blocker 20 tablets, okay, and does not have hypotension. Would you still give this to that patient? Just what will happen if the patient has got calcium channel blocker toxicity had taken, and he's taken
So
around?
if the patient is asymptomatic, we'll wait and watch, sir, until the
How long you'll wait? How long you'll wait?
Until the drug effect,
Drug elimination, sir.
How
Usually
long is that?
five times the T half of your drug.
Very good, very good. So you'll wait for how long inside? So what will be your order when you come and see your patient? How long you'll wait? So your same clinic depend. How long you'll wait?
We'll see if it is a immediate release or sustained release, sir. If it is an immediate release, we'll wait for 8 to 10 hours, sir. If it is sustained release, we have to wait for 18 to 24 hours, sir.
And look for what?
And look for any ECG changes, hemodynamic instability.
So you are okay giving noradrenaline. What if this patient had got myocardial depression along with blood pressure on the lower side? EF is 40%, is 15% because of myocardial suppression, 20%, and you have a hypotension happening. Would you want to give still noradrenaline, or would you want to give something else?
We can go with dopamine, sir.
Dopamine is kind of contraindicated in these cases.
Dopamine, sir.
No.
First,
No.
any agent is
Okay.
noradrenaline only, sir. In cardiogenic shock also, noradrenaline is the first drug of choice. And then if at all, if still it is there, to increase your contractility, we can give dobutamine, sir. But the first agent of choice is noradrenaline.
Okay. What about epinephrine?
Adrenaline. Adrenaline
Hello.
is the
Hello?
choice, sir.
What do you think about epinephrine as a first drug compared to noradrenaline?
More chances of arrhythmia, sir. So, but first we prefer norepinephrine, and then if still is not, then we can choose epinephrine as a second line of drug.
Is it true? But what do you think is the inotrope of choice in a patient with calcium channel blocker poison? Hello?
Yes,
Sir.
Which is the inotrope of choice? Is it noradrenaline or epinephrine? Adrenaline. Especially
based upon
when
the EF prior comorbidities of, or if the patient is a cardiac patient, based on the EF, if we'll start, sir. If there are no comorbidities, then we'll go with noradrenaline. Prior cardiac history is not there, means we'll go with noradrenaline, sir. If as you said, if the EF is low, and then we'll start with epinephrine, sir.
Okay. See, I'm just going to ask you one thing. Can you just summarize in one word, one sentence, the rationale for using actrapid and dextrose or insulin dextrose high dose in these patients? With maybe the rationale. You did say something.
Sir, it has positive inotropic effect, sir.
No, that's not the reason. The reason is calcium channel block, as you said the second time, decreases insulin release. Is it not?
Yes, sir. Hypoinsulinemia will be there. So it
so hypoinsulinemia with the sort of relative acquired insulin resistance. And that's the reason. And that's the reason that you actually give insulin, and obviously to mitigate the effect of insulin, you also give glucose if that is necessary. Remember that hypotension, bradycardia, and hyperglycemia are usually seen in patients with calcium channel blocker. Is there any reason why you didn't see bradycardia in your patient?
Dihydropyridines usually to some extent there will be hypotension and reflex tachycardia. As the toxicity increases in severe cases, then even they will present with bradyarrhythmias, sir.
Okay, verapamil will cause bradycardia.
Bradyarrhythmias, non-dihydropyridines.
Okay. Now this clinidipine that you told about, how is it different from amlodipine in terms of its mechanism of action? Amlodipine is a
it acts on L-type voltage gated calcium channels, sir. Whereas cilnidipine, it acts on both L-type and T-type calcium channel blockers.
T-type or N-type?
L-type and T-types.
L-type and N-type or L-type? Okay. So because it acts on the N-type, it reduces the neurohormonal stimulation. Okay. So you don't see that much of reflex with these patients, but this particular patient did have tachycardia. That's fine. So you did give the actrapid because of an acquired insulin resistance, and you would have chosen probably epinephrine if the patient had a contractility problem, and maybe if he also had bradycardia. Then since this patient probably had a normal contraction and maybe tachycardia, you didn't want to choose noradrenaline. But would you agree with me that generally the inotrope of choice would be epinephrine in patients in routine calcium channel blocker poisoning?
Yes.
No? Yes, no? You could disagree also. I'm just asking you.
So if there is myocardial depression, we can go with the epinephrine. So.
Okay. Okay, then please continue.
So I saw that you started actrapid. Now, how do you titrate actrapid? I mean, you started 0.5 units per kilogram per hour, which I think is a very low dose, actually, if you ask me. Okay, yes. It's 0.5 units per kilogram is you just now said hyperinsulinemic and all these things. When you say 0.5 units per kilogram, it's barely 25 units an hour, which is barely a dose to actually look at toxicity. What should be the actual dose?
Sir, usually initially 1 unit per kg
Ah.
bolus will give,
Bolus
sir,
we
and
give.
after
Yeah.
that we'll start with 0.5 units per kg per hour, and we can increase up to 10 units per kg per hour, sir.
Why you do not give this bolus here? Huh? That bolus should have been there here, because without that bolus, this was 0.5 units per kilogram per hour is an infusion. So it will not even work unless 0.5 units per kilo go over 1 hour. So the important thing is to actually get the insulin up as quickly as possible, isn't it? Because you just now said so many beneficial effects of insulin, isn't it? So
Yes.
insulin is acting actually like a inotropic agent for you. And if it is acting like an inotropic agent for you, it is not acceptable that you give such a small dose over that also as an infusion. It has to be given as a bolus, isn't
Bolus. Yes.
it? So if you have started a bolus and you started an infusion at a unit per kilogram per hour, okay, when do you further titrate it? You said it can go up to, you said 10 units per kilogram per hour, isn't it?
Yes, sir.
Yes.
Yes.
Huh? So how
Yes.
do you titrate it, and based on what?
Depending upon your hemodynamic, basically
After-
hypotension, you can increase your infusion rate to up by 50%, sir, every 20 minutes.
Every
In
20
case-
minutes. Yeah. So the key in calcium channel blocker, you might have realized by now, is every 20 minutes.
Yes.
Isn't it? So everything is every 20 minutes. Isn't it? Everything every 20 minutes. What can occur wrong if you use a high dose, say 10 units a kilogram? What can occur wrong? What can occur?
Hypoglycemia
Hypoglycemia.
and
Okay.
hypokalemia.
Hypokalemia, very good. So you'll be sending your potassium more regularly. You'll be sending your what else you want to send?
Glucose.
Your sugars regularly. What else it can cause? You are giving dextrose, no?
Yes, sir.
Extreme amount of dextrose. Because you'll end up giving higher doses. See, 200 ml IV stat, and you'll also be giving dextrose along with it, isn't it?
Yes, sir.
It cannot be just 200 ml stat. There has to be an infusion that will titrate this. You cannot give actrapid and just increase actrapid, right?
Yes, sir.
So you'll be giving either a 5 or a 10 or a 25% glucose all the time.
dextrose. Yes, sir.
Yes.
Yeah.
Yes,
If that
sir.
happens, then what are you going to look at? Sodium levels?
Yes, sir. There will be hyponatremia.
Yeah, there is going to be gross hyponatremia when you're going to give so much of dextrose. See, imagine you're giving 50 units a kilo, 50 units an hour, and you at the meantime you even said 500 units an hour. If you're going to give 500 units per hour, you'll be requiring loads of 25% dextrose, isn't it?
Yes, sir.
Yes.
And when you're giving so much of glucose, 70 grams an hour or something glucose you'll be giving, at that dose, you will probably require extreme monitoring of acid-base status, extreme monitoring of sodium, potassium. So those all things should be there here, isn't it?
Yes, sir.
Huh?
Yes,
So now you tell me that if this gets the blood, will this get the if the insulin is getting the blood pressure up, how does it get the blood pressure up? Say you have a cardiac output monitor, you have a pico catheter inside. Okay, you have a cardiac output monitor inside. Which value on the cardiac output monitor will change? So I'll give you the options. You have cardiac CO, CI, you have SVR, you have EF. So which of these will actually improve? PVPI, which will improve? What of these?
Cardiac
Or all will
index,
improve?
sir.
Sorry?
Cardiac index, sir.
What about SVR?
SVR also increases, sir.
SVR will increase because, so if SVR increases, we don't need NORAD, no?
It will not increase.
If SVR would increase, we will not require NORAD as much. So how do you titrate? That's the question is, how do you titrate this activity? Yes, based on blood pressure, you're right. You're going to titrate your insulin. You're going to titrate again based on ejection fraction and myocardial contractility, isn't it?
Yes, sir.
Because that is going to cause the blood pressure to go up. In fact, the answer to the question of high dose insulin is vasodilatation. See, if you give high dose insulin, one side effect that you can get with high dose insulin is extreme vasodilatation.
Coronary and pulmonary vasodilatation.
Yes, that is what you're going to get. You're going to get vasodilatation, and that vasodilatation can be quite disastrous. You understand? So at this stage, you cannot cut off your NORAD even though the blood pressure has come up. You understand this?
Okay, sir.
Yeah, that's what I was asking you. What are you going to do with the NORAD? Okay, let's go ahead.
Now, patient was shifted to AMC for further management. She was complaining of nausea and headache. In general examination, patient was conscious, coherent, no patellar cyanosis clubbing, lymphadenopathy or pedal edema. Fresh hesitation cut marks were present on left forearm. On her vitals, BP was 90/70 on NORAD 4 ml per hour, heart rate of 136, saturation 98 on room air, and respiratory rate of 22, and GRBS was 142, sir. ECG was sinus tachy, and PR interval was normal.
So your patient has improved even though you gave wrong calcium, wrong insulin. Huh? So, okay. So what if it doesn't work? It's still not working. BP is 90, isn't it? What are you going to do?
We'll increase the insulin dose, sir, and we'll start on intralipid and glucagon also, sir.
How do you give intralipid?
Intralipid 20% solution, sir. Initially 1.5 ml per kg bolus will give, sir, over 1 minute, and then we'll give 0.25 to 0.5 ml per kg, sir.
So this intralipid is, why is it given?
That's the doses.
Sir, it acts as a lipid sink therapy, sir. It absorbs the toxic substance into the core, sir. Highly lipophilic substances, it will absorb into the core, sir, and prevents its absorption, sir.
Okay, but then, but don't you feel, is this is what can occur with this? I mean, I know you want to use this, but are we using it on a regular basis? Have you used it for calcium channel blocker toxicity?
Yes, sir. We used it in this patient, sir.
So what will happen? Say, how is the movement? Now, the other day you told me about, other time you told me about activated charcoal. How does the drug move here?
It is a more lipophilic drugs, a more volume, increased volume of distribution will be there.
But what can lipid do? Where you're giving the lipid? Inside the gut or inside the vasculature?
Inside the vasculature, sir.
So what is going to happen?
It will pull the drug into the lipid phase, sir.
It will pull the drug into the vasculature?
No.
It has to, no?
Yes.
It has to do that, right? If you're going to do this, there is going to be a translocation of the particular drug from the GI tract into the vasculature. Are you right on that? Are we right on that?
Yeah.
And that movement is not going to be this way, that the drug is going to go and stick only onto the lipid. Because of the gradient, it is going to move faster out of the intestine. In fact, the intoxication can worsen. Can it worsen or not? Yes, it can worsen. That's what you're supposed to look at. It can worsen, and that's the reason that intralipid is not taken as first line therapy. Otherwise, we would have given intralipid on first go, isn't it?
Yes, sir.
Right?
Yes, sir.
So what is the maximum dose of intralipid you can give? Say, for example, you started something and there was a response. That means so how you're going to titrate this again? You're going to look at the response, isn't it? You're going to look at the blood pressure again. Now the blood pressure has improved and again it has gone down. What do you do now?
Sir, we can repeat a bolus, sir, but the maximum dose shouldn't exceed 12.5 ml per kg per day.
Per day, yes, per
Yes.
day. Per day.
Fine.
Yeah.
Okay. You did talk about the intralipid sink. So, and you talked about a dose. You said you will give 1.5 ml per kg bolus followed by 0.25 milligram per kg, right? Per
Yes.
minute.
Yes.
Fine. That's the dose for a weight less than 70 kgs. Is
Yes.
it not?
Yes.
So what will be the dose for a person who's more than 70 kgs?
We'll give 100 ml over 30 minutes, sir.
Okay, 100 ml bolus of 20% lipid. Then
Yes.
Bolus is not 30 minutes, huh?
Bolus
it's
is
not- it's the
over
bolus.
Over
1 minute.
1 minute.
Yeah, over 3
Okay,
minutes.
100
3
ml.
minutes, not more than that.
Yeah, 100 ml bolus of 20% lipid plus then
And if there is no response, you can repeat it for every 3 to 5 minutes. For maximum up to 3 bolus doses, we can give.
200 to 250 ml you will give over the next few hours, is it not?
Yes.
Okay, you did talk about the lipid sink, and the previous was telling how there is a lot of controversy in the use of lipid sink. Now, can you tell me where lipid sink has been conclusively proven to be of benefit? In which type of
Local
Local
anesthetic
anesthetic
systemic
toxicity.
Local
toxicity.
anesthetic.
Again,
Okay, in those. Among, yes, I understand it's been used in beta blockers, calcium channel, maybe even in paraquat. There've been case reports. Yes, I do understand. Is there is this the only benefit of using a lipid sink? Is there any other that it absorbs the drives the drug
It's a
into
fatty
the-
acid.
acid also it will provide the myocardium the energy source.
Energy source, and it helps in improving your cardiac function, contract.
Okay, you say that the preferred source of energy for the
Energy,
myocardium is
myocardium,
the
fatty
free
acid.
fatty acids, and it provides that. Okay, so tell me which calcium channel blocker has got the maximum case reports with the lipid sink, if at all? Is it with clinidipine or is it with other calcium channel blockers
Amlodipine, sir.
or verapamil?
Verapamil.
Okay. Do you think if you don't give lipid sink, it is wrong in this patient? Do you have to? I mean, what I'm trying to say is there a conclusive role of lipid sink or intralipid in these patients? Is it okay not to give? Should be given, can be considered, can be considered.
It can be
It can be
considered,
considered, sir. It's like it should not. It's not like it should be.
Okay, fine. You did talk about hesitant cuts present on our left forearm.
Yes.
What does that indicate?
Suicidal tendency. She's having suicidal tendencies.
Okay, fine. Please continue.
Central line right IJV and arterial line right radial artery were placed, sir. Initially, patient was resuscitated with IV fluids and vasopressor. IV fluids, RL or plasmolite, was started at 75 ml per hour, and injection in human ectopid was started at 0.5 unit per kg per hour, which was increased to 0.7 unit per kg per hour, along with 25% dextrose infusion at 25 ml per hour.
Okay.
Lipid emulsion therapy was initiated, and injection intralipid emulsion 20% 1.5 ml per kg IV bolus followed by 0.25 ml per kg per hour was initiated. In view of persistent hypotension, injection glucagon 5 mg IV stat was given and infusion started at 5 mg per hour. Sir.
Glucagon.
Yes, sir.
This was available in the hospital.
Yes, sir.
Yes.
Oh, okay. But is glucagon a recommended therapy for calcium channel blockade?
It is
Mostly for
most
beta blockers,
beta blockers. Sir.
So then why did you give it for this?
But in calcium channel blocker also, glucagon is can be used. Sir.
Why would it work in calcium channel blockade? I mean, please let me know why it would work in calcium channel blockade.
Glucagon binds with glucagon receptors, sir, and it stimulates the adenylate cyclase, so which increases cyclic AMP and increases the intracellular calcium, sir.
Okay. Then if that is the case, milrinone should also work. Milrinone does the same thing, isn't it?
Yes, sir.
Then milrinone should also work. Why not give milrinone? Because if I were to give glucagon, I would probably need to give it, as a continuous infusion for very, very long period of time, isn't it?
Yes.
Because what is the half-life of glucagon? Why are you giving it as an infusion?
3 to 5 minutes.
3 to 5 minutes.
It's 15 minutes. 15 minutes.
Okay.
It's 15 minutes. It's not 3 to 5 minutes. But okay, because if you start using how does glucagon come? Have you seen glucagon? Since you used it, how does glucagon come?
In vial.
1 ml ampule, sir, like in a vial.
So how many you will require? You'll require the whole stock of the hospital if you want to give glucagon.
Yes.
It's that much amount of vials you'll require. 5 milligrams an hour if you talk, you'll require the whole stock of the hospital. That's the amount you'll require. It doesn't come as an infusion pump. It doesn't come as an IV bottle. It comes as small ampules.
Yes, sir.
So you really use glucagon? I really want to ask you this.
We used in this patient, sir.
And you give it 5 milligram an hour?
Yes, sir. We gave 5 mg per hour, sir.
And then why did you stop it? Then you stopped it or you just continued it?
Sir, on the day 2, we stopped it, sir, because her BP was improving, sir.
So up to whether we waited up to day 2, up till day 2, she had a low blood pressure. Didn't she go into renal failure and DIC and all with low blood pressure?
No, sir. Actually, on day 1, she came at 10 o'clock in the night, sir. So in the day 2 morning, we stopped it, sir.
So roughly you're given for 10 hours, 12 hours, maybe. That's it. Is that
10 to 12.
8 hours.
8 hours? Okay. So you did tell us that glucagon is not the drug of choice, one of the drug of choice for calcium channel blockers. Is more for beta blockers. But in view of persistent hypertension, you also considered using glucagon, right?
Yes.
That's what you told us. Okay. I'm just curious, just sidetracking. How does glucagon help in beta blocker poisoning?
It's the same thing. You just told the answer, isn't it?
Yes, sir.
What is the answer?
It increases cyclic AMP levels, and it increases intracellular calcium, which increases the contractility, sir.
So basically it bypasses the beta receptor, isn't
Beta
it?
receptors, yes. Beta receptor independent catecholamine.
Yeah. And that is the reason it probably works in beta blocker toxicity.
Yes, sir.
So I come back to the same question. Why would you use milrinone? Because it's got the same activity, calcium cyclic AMP, isn't it? So where would you use? It's okay. This is an absolutely difficult question. Where would you use milrinone versus glucagon? What happens if you give glucagon? What is the possibility?
Sir?
What is the problem with glucagon? What does glucagon cause at this dose?
What adverse side effects of glucagon?
Hyperglycemia. There will be transient.
What am I worried? This is a patient who's in toxicity.
Tachyphylaxis.
No.
Okay. Any electrolyte abnormalities?
Hypokalemia. Initially transient hyperkalemia followed by hypokalemia.
I'm almost near about certain that you haven't given this glucagon, because 5 milligram an hour would probably cause this patient to get vomiting. MSS is a very important side effect of glucagon. Very important side effect. So usually, if this patient has got a chance of vomiting, which this patient would have because he's got situation where he's hypotensive, where he's not responded, the chances of this is very high. MSS is very high. That is where probably milrinone would be given, especially if the patient is bradycardic. This patient is not even bradycardic. Glucagon will actually work when there is bradycardia more than tachycardia. Though it's a cardiac pump failure, it's most useful in bradycardic beta block patients, isn't it? Okay. So what is the glucagon test dose?
2 to 5 mg initial bolus will give, sir.
So why did you give it here? Test dose. What is the test dose required for?
To look for the response.
Yes. So if you look for the response, what do you do then?
We'll start the infusion.
At what rate?
At which the response has, at the dose at which the response has come.
So that's why I'm near about certain that this is not how we have done it, because glucagon normally is given at a bolus dose, and then at the rate at which the patient actually responds, you start an infusion, isn't it?
Yes, sir.
So if you would have given glucagon, you said I gave 5, it didn't improve, I gave 10 and it improved, so I started 10. And based on your cardiac inotropicity, isn't it?
Give them the benefit of doubt. Maybe they had given 5 milligram stat, it improved, and that's why they continued at 5 milligram per hour.
Yeah. So we take it that 5 milligram you improved everything and it has gone. So it's good. It's good that you did that. Glucagon 5 milligram IV stat. Okay, let's go ahead.
And while you're still with glucagon, what is usually loading dose of glucagon? Can you tell it per kg? Is there any particular dose per kg that has been given?
Yes.
Is it some 50 microgram per kg?
50 microgram per kg.
Okay, what's the maximum dose of infusion that you can go to? You're now giving 5 milligram per hour. What is the will it be 15 milligram per hour?
5 to
Okay,
10
so
mg.
just summarizing, as Sandeep said, glucagon increases heart rate, increases myocardial contractility, and increases AV conduction. So in the typical calcium channel blocker poisoning, especially with verapamil and other things that you get, where you will have problems with the heart rate and AV conduction and also contractility, because verapamil all are drugs that decrease the contractility. There it will be more useful, or in patients with beta blocker, it will be very useful. So the side effects that he said, nausea, vomiting will be limiting side effects. Hyperglycemia will be limiting side effect. And as you said, hypokalemia is something that you will actually watch out for. Okay. So, and you agree that glucagon is not the drug of choice in calcium channel blocker. It is probably more with beta blocker. But since this patient is in persistent hypotension, you've tried calcium, you've tried an inotrope, and you've tried high dose dextrose. High dose insulin dextrose potassium, and therefore you've gone to glucagon. Is that the rationale?
Yes, sir.
Right?
Yes, sir.
Okay. If the patient had improved with all of that, you wouldn't have started glucagon, right?
Yes, sir.
Yes.
Okay. How costly is glucagon?
One ampule is around 1,000 rupees, sir.
Okay. So how much did this particular patient spend with the glucagon?
Sir, almost 20 ampules used it.
Okay. Okay.
More than
More
20 ampules.
Okay. Please continue.
Treatment. Treatment injection human atropine 35 units per hour and 25% of dextrose 100 ml plus 40 milligrams of KCl at 25 ml per hour was started, sir. And intralipid 20% 25 ml per hour and calcium gluconate at 25 milligrams per hour. And glucagon 5 mg IV stat was given and infusion started at 5 mg per hour and noradrenaline around 0.7 mics per kg per minute. Blood glucose, potassium levels and ionized calcium levels were regularly monitored.
So, I mean, you're giving a really, really big dose of potassium, 20 milliequivalents, 10 milliequivalents an hour you're giving, isn't it? I mean, why is this a big dose? I feel this is a very big dose. Why are you giving so much of potassium? You monitored the potassium, is it?
Yes, sir.
Regular monitoring was there, sir, ABG and also.
So his potassium was low, is it?
No, sir, but because
Of the insulin
we
to
were
counteract
giving
that
to counter.
hypokalemia, we gave
Okay.
potassium.
So what can happen when you give such high doses? Just for my knowledge, like say this patient gets better, what is going to happen? Say this patient gets better, what is going to happen? So my question is, how does a GI drip work? Because you're giving glucose, you're not giving insulin, isn't it? What happens when you give glucose and insulin? What is happening to the potassium?
Hypokalemia.
How? Where is potassium going? Is it going through the kidney or is it going into the cell?
Into the cell. It is going into the
Intracellular.
intracellular
Okay,
shift will
it's
be
going
there.
intracellular. What is going to happen when you stop treatment?
Hyperkalemia.
Exactly. So when you give a high dose of potassium that's on the higher side, when you stop your treatment, what is going to happen to all this potassium that's going to come out?
Yes, sir.
It's all going to come out, isn't it? So you must be very careful. So I would put it this way, that all your potassium replacement has to be, in fact, less aggressive than what you're doing. It's not like how you're going to give a otherwise conventional potassium. You understand? So it has to be less aggressive. You understand, right? Why?
Yes.
You understood this, right?
Yes.
Yeah. Go ahead.
This was on day 2 of admission. The patient had was complained of more increased nausea, vomiting, headache, and ABG was showing severe metabolic acidosis with hyperkalemia, and potassium was around 9. So nephrology consultation was taken and sled was initiated.
Wow. The potassium that you did give has translocated. So what is the total potassium that the patient received? Looks like how many milliequivalents did the patient receive?
Sir, in 500 ml IV fluid, we have added in every bottle 40 milliequivalents. Sir.
So totally how much milliequivalents was given to him?
80
200.
milliequivalents. 80
That's all.
milliequivalents. Yes, sir.
That's all.
Yes, sir.
How do you explain this hyperkalemia?
It's too much. It's 9 is just too much. How did this occur? I mean, was it a potassium line from where you took it? 9 is just too much, isn't it?
No, sir. It can be because of the transient hyperkalemic effect of the glucagon, sir, or it can be because of the acidosis also, sir.
Your acidosis was not too bad. Your pH is 7.41,
It's
as you're
yes.
showing here. So that's hardly any acidosis. That's in fact normal pH, is it not? I mean, I do understand that the bicarb is low, but it's
Yes.
been fairly compensated. There's no acidemia. There is at least compensated for now. So,
Yes.
Can't explain this. Can't explain this. And what was the ECG at this time?
The same sinus tachy was there, sir, and
It's very difficult to understand why a patient would be still in sinus tachy when such high potassiums and such high overdoses of blockers, calcium channel blockers. Because especially in toxic doses, this seems to be extremely toxic doses. You can't have reflex tachycardia. You'll probably have bradycardia if there is toxic doses. This entire case looks like it is a very high dose calcium channel blocker, isn't it? And
Yes.
if it's a very high dose calcium channel blocker, we don't expect reflex tachycardia. That occurs in therapeutic doses. It occurs in doses that are slightly more than therapeutic, not really, really very toxic doses. The reflex tachycardia that you see would be masked, no, because selectivity will go. So you will probably have bradycardia here. I'm surprised how you have tachycardia with this particular patient. Any which ways.
that's exactly it. That's exactly what we are trying to find out from before. Usually, bradycardia, hypotension, and hyperglycemia are probably the hallmark there. But I do see that your potassium on the ABC is also 8.18, and your
Yes.
serum potassium is 9.
Yes,
So
sir.
that correlates. So you've taken from two different sources,
Yes.
the radial line and maybe from a prick or from a central line. So
Yes,
it's
sir.
still 9. So and you're given only 80 milliequivalents of potassium.
Yes, sir.
Is it not?
Yes, sir.
So do you think we can actually explain this hyperkalemia? Do you have a logical explanation, at least?
So it can be due to the transient hyperkalemia which glucagon can cause, sir. So we are thinking about that.
But
And
with
then,
this
and then you know, you also took a nephrology consult and you actually started SLED. Now at this potassium, SLED would be absolutely low efficiency, isn't it?
Yes, sir.
So why did you think of starting SLED here?
Because she's on vasopressor support, hemodynamic instability is also.
That's very surprising. No, day 2 this is. If it is day 2, most of your drugs would have moved off. Why is she still
Sir,
hypotensive?
actually,
See, you are on 25 tablets, right?
But
Now
it was not 24 hours didn't pass, sir. She came before on day 1. She came at evening 8 o'clock, sir. So by the time she was shifted to AMCU, it was 10:30, sir. So day 2 in the morning, the ABG was this, sir.
Okay. I thought you were given 40 milligrams per hour potassium, right? That's what your previous slides. It goes back to your previous slide.
yeah.
Yes, sir, but it was added in the 500 ml thing we have added.
Please go back. Please go back to the previous slide.
100 ml plus 40 milliequivalents
Sir,
at 25
but
ml per
this
hour.
40 milliequivalents was added in 500 ml NS, sir. I mean 500 ml IV fluid it was added, sir.
And going at 25 ml per hour.
That's hardly a dose.
Okay. I still can't explain why this happens. Anyway, since you've said that there is hyperkalemia that has happened, have you done some research and found out what are the situations where hyperkalemia can happen with calcium channel blocker poisoning?
Everywhere it was hypokalemia only, sir.
Okay. Okay. Have you heard?
Sir,
And then hyperkalemia. That's been reported with calcium channel blocker poisons, but this particular patient had none of the others. She probably has only hyperkalemia, no bradycardia, no renal failure. Renal functions are normal, no? No AV nodal problems. Shock is there. So I can't really explain the. Dr. Sanjay, do you think you have a reason to explain this?
No, this cannot happen. This cannot normally happen. It is not possible for this to happen because you are giving only 40 milliequivalents. That also it comes to around 10 milliequivalents an hour is what you're giving. 25 ml per hour. That's the max you're giving. There is no reason why you should have hyperkalemia of this nature. 9 milliequivalents is just too much. It's just too much. Yeah, let's go ahead. But this patient is already still hypotensive. You have gone up to the maximum dose of calcium. You have gone to the maximum dose of insulin, and still the patient is hypotensive. So is there anything else you could have tried here? Anything else? Do you know anything else you could have tried here? Anything that is investigational that can be used as tier 2 therapy?
If there is myocardial depression, in spite of all these things, we can go for extracorporeal.
That's okay. Before that, is there some drug that was tried and tested in sepsis that you could have tried here?
Methylene blue.
Yeah. So how does that work? How does that work?
Sir, it prevents the nitric oxide synthase activity, sir. So the vasodilation won't happen. Vasoconstriction happens.
Yeah, so you could try methylene blue. What is the dose?
2 mg per kg, sir.
Yeah. And do you give it just as a bolus or do you start an infusion?
Initially, we'll give bolus 2 mg per kg, sir, and we'll see for the effect, sir. If there is no effect, we can repeat again and start infusion, sir.
Okay. But then, this patient has been a very long time, as you rightly said. You would probably need to go ahead faster than what you're doing now. Okay. So do you think that hemodialysis sled that you're doing will remove the drug out?
Yes, sir.
Oh.
No, sir. Drug it won't remove, sir. For hyperkalemia, we did dialysis, sir.
For hyperkalemia. So which drugs you will probably want to use dialysis for in a similar presentation?
So for barbiturates.
No, a similar presentation. I'm talking of hypotension, bradycardia.
Atenolol for beta.
Yeah, very good. Very good. So which kind of beta blockers these are called as?
Non-selective beta blocker.
Hydrophilic.
Yes.
Hydrophilic. Yeah. Okay. So this is your X-ray. What is that? A pacing wire? You have a pacing wire in place?
No, so those are the ECG leads.
Okay, this big line is the dialysis line, is it?
Yes, sir. Yes.
Okay. All right.
The post-dialysis ABG, her potassium was around 5.5, sir, and ionized calcium was 1.35.
How much time later this happened?
This was after 6 hours of sled, sir.
Oh. That's nice.
Okay.
This is in this the serial ABG, sir, from the starting day one to check about the ionized calcium levels, which was around almost 1.08 to 1.38 and 1.15, sir.
Okay, in ABG3, there is something that we are seeing. The glucose is very low, right?
Yes, sir. Yes, sir.
65. So that's
In between,
so
we
at
had
that
to
point.
give. In between, we had to give boluses
Bolus
of 25%
25%.
dextrose also, sir, depending upon her glucose.
And then you went to reflect, you went into hypokalemia also, sir. 2.97 is the potassium, the last ABG.
Sir, but that serum value was 3.5, sir.
Okay. So the hyperkalemia came unexpectedly, then it was corrected.
Yes, sir.
There was some degree of hypoglycemia which you did pick up. So how frequently were you checking the
Every half an hour we were checking, sir. Every 30 minutes we were checking, sir.
And how frequently were you checking the potassium?
Potassium, every 2 hourly we are sending serum samples, sir.
Hmm. Okay, then. Fine. Continue, please.
Yes.
This table is showing the requirement of vasopressors, insulin, glucose on respective day 2, 3, 4, and 5, sir. Initially, insulin we started at 35 units per hour, sir, and on day 3 we have gradually weaned off and we have stopped it, sir. Glucagon also 5 mg per hour we've stopped on day 2 itself, sir, and calcium gluconate 25 milliequivalents per hour stopped on day 2, sir. NORAD also was gradually weaned and stopped at day 3, sir. Vitals were 90 by 50 on day 2, sir. With a maximum blood pressure of 110 by 70, and blood pressure on day 3 was maximum 120 by 70, and the tachycardia also is coming down, sir. It is 110 per minute, sir. And the urine output on an average, it was 150 ml per hour, sir, on day 2. On day 4, we have allowed her on, she was completely off all the infusions, sir. We have allowed her on liquids, sir. And Folis was removed and her vitals, she's hemodynamically stable, sir.
So this patient did have tachycardia. What if this patient had bradycardia? Would anything change? Would
Yes.
anything change in this?
Yes, sir.
What would happen?
If the patient is having bradycardia and bradyarrhythmias, then initially we'll go for atropine,
Roll of
sir.
atropine.
0.5 mg up to 3 doses we'll give, sir. In the meanwhile, it will place a pacing wire also, sir.
So pacing will work. What are the problems? Does this patient have a conduction system problem or a myocardial problem?
Myocardial problem, sir.
Then how will a pacing work? You're understanding? A pacing is for what? A conduction problem, isn't it?
Yes.
So how will a myocardial system work? In fact, what will happen when you have this patient on pacing? Will the atrial kick remain or not remain?
It will sense. It will pace
the ventricle because it's temporary pacing.
Yes,
What will
sir.
happen to the QRS?
Wide.
Yeah, exactly. It'll get
QRS.
wide. So if it gets wide, you already have a widened QRS because there's bradycardia. So do you think transcutaneous pacing will be effective? Transvenous pacing will be effective? Less likely, no? So what do you do? So to know whether it's working or not, what do you do? Something very simple you can do. Before you insert a wire inside, what you could do?
Atropine.
You can try transcutaneous pacing, isn't it?
Yes, sir.
So if transcutaneous pacing works, okay, it is even less likely to succeed actually. But if you want to actually use transcutaneous pacing and it kind of improves your blood pressure, then probably you could think of transvenous pacing. But do you agree with the fact that transvenous pacing may not be a great idea? Especially when the patient has got bradycardia and all these things which are coming as a result of not the native conduction having a problem, but the myocardial suppression, isn't it?
Yes, sir.
Could be a problem, isn't it? Anything else would change in your management? You said atropine. What about inotropes?
Epinephrine. You can
Probably want to give epinephrine, isn't it?
Yes, sir.
So epinephrine would change. So bradycardia hypotension will probably start epinephrine. Dr. Dedeepiya also said the same thing itself, that epinephrine is something that will probably work, isn't
Yes,
it?
sir.
Yeah. All right. Okay.
These were the serial calcium and potassium levels on day 1 to day 4, sir. On day 1, it was 10.8, and day 2, 11.4, day 3, 9.2, and day 4 of 8.8. And potassium, day 1 was 4 millicoulomb, and day 2, 9, and after dialysis, it was 5.5. And on day 3, it was 4.2.
So I strongly believe that the hyperkalemia that came in is not related to anything that you did. It's probably maybe a co-ingestion of some poisoning. So how do you find out that?
Sir, the patient
because we all discussed why there is hyperkalemia, isn't it? We all discussed.
Yes,
And we didn't find a possible reason. It doesn't seem to be you, and you actually put up sled for the hyperkalemia, which we did not expect in any way. So what could this have been? Could there be a co-ingestion of something? So how do you find out whether there's a co-ingestion? What do you do?
Initially, we'll take a history, good history, sir,
told
and
you-
we'll.
She only told you about clinidipine. What else would you want to test?
Urine toxicology.
Yeah. So that is where we have not done a toxicology screen at all here.
But the patient, she herself told that she had 25 tablets and the strip was also available, sir, which she took.
Yeah. So I agree to what you're saying, but it really doesn't fit the picture at all, isn't it? It doesn't fit the picture at all. I mean, I've told you where you've listened to her, you've taken her history, and she's told you this, but it doesn't fit, isn't it? If it doesn't fit, then probably, and also, don't you think medico-legally it would be important for you to take a toxicology and preserve the gastric lavage fluid?
Yes.
Medico-legally, would you not want to keep this, because if the Panchanama occurs, they will ask you for it, isn't it?
Yes, sir.
So anyways, that should have been sent is what I feel. I don't know what Dr. Dedeepiya feels. What do you feel?
I mean, basically, though it's recommended, I think on a practical purpose, most of the toxicology screens that are available don't test for anything other than benzodiazepines, opioids, others. They don't really test. So most.
So I don't know how is it in Karnataka. In Maharashtra, when we actually send off, when we actually take out gastric lavage fluid, we have to preserve it because it is sent to the forensic laboratory.
Do they test for all the drugs?
It goes to a toxicology lab where they test for it. So we don't get to know. We get to know only later on.
So does it actually help in the patient management?
No, doesn't at all. But medico-legally, if we don't keep it, then there is a problem medico-legally. They may also not test it, but then they write it on paper that the doctor hasn't preserved the sample. If you know the Salman Khan incident.
Okay. Yeah. Okay. So here in our part, we don't preserve, but ideally, yes, theoretically speaking, if you're able to get information on what the patient takes, especially in this particular patient, because we can't really explain the hyperkalemia. Maybe it's a co-ingestion. That's what I was also thinking, but we couldn't demonstrate it. So I think for that reason it is. But on a practical purpose, I think it doesn't help because the information that we seek to help the patient doesn't come at all, or even if it comes too very late. So,
And also,
but-
these particular tests do not stand in court of law because they are not the required test. It's not mass spectrometry. It is a point of care analysis. So they normally don't even work in a court of law, these particular tests.
sure.
Moreover, you will not
Sure.
know whether it is therapeutic or toxic. It doesn't really qualitative tests. They are usually not quantitative tests.
Yeah.
Yeah. Yeah, go ahead. So pantoprazole 40 milligram oral. What is Mixon?
Mioxone multivitamins.
Oh, multivitamins. And Calcium Max Fort,
Calcium
one
Max.
tablet.
Mhm.
All right. I think it's a very fantastic case that you presented, and I'm very happy to see such a case. I mean, very difficult case to actually get through. I mean, a fantastic job done by Ola to get out of this case, because it's something that you have done as per textbook picture. I felt a lot of things that you have done. Few changes could have been done here and there, but fantastic outcome.
Good. Entirely agree with Dr. Sandeep. You've taken good efforts in taking this case. So before we conclude, or rather before we, as a parting point, so in calcium channel blocker poisoning, if I were to ask you, what are the clinical features you expect?
Hypotension,
Nausea, giddiness, vomiting, hypotension,
bradyarrhythmias,
And hyperglycemia,
hyperglycemia.
and AV conduction disturbances can
Yes,
happen.
yes.
Okay. So you did talk about activated charcoal. You just said that it will be useful if it's given within 2 hours. And we said that beyond 6 hours, it will not be useful. We did tell you about, you did use the right dose of 1 gram per kg. You tried to resist the patient with fluids. Okay, now just coming to asking you, you've used a lot of these drugs. So if I were to ask you in sequence, if a patient comes with a known poisoning, which in this case is a calcium channel blocker poisoning, overdose, what is the sequence in which you use your drugs? If they have cardiotoxicity, which this particular patient had. It's cardiotoxicity because he did have hypotension, is it not?
yes, sir.
So-
So, apart from airway, breathing, circulation, IV fluids, and vasopressors, we will start IV calcium salts, sir. Then,
So IV calcium is first.
yes, sir.
followed
High
by?
dose insulin
Insulin.
therapy with dextrose, sir.
Is there anything between these between calcium and high dose insulin dextrose? Is there anything between?
If it's a beta blocker, then glucagon is first choice.
No. Is epinephrine not in between these two? For calcium channel
Vasopressors,
blocker poisoning?
yes,
Yeah, usually in your case, I wouldn't argue if you use noradrenaline, because you did have tachycardia already, but
Yes.
generally, and you had a normal ejection fraction, but generally in most typical calcium channel blockers where you do have bradycardia and hypotension and myocardial concurrently, you would give calcium channel calcium salts followed by epinephrine, followed by high dose insulin. Dextrose potassium, which is did. And yes. So would you want to give the lipid sink in all cases or in selected cases? You did use the lipid sink.
Yes, sir.
So do you want to use it in all cases or in select cases? How do you make that distinction? I'm going to use in this patient, I'm not going to use in this patient.
More lipophilic drugs we usually prefer, sir. More of
Lipid emulsions, apart from local anesthetic toxicity, we can use in calcium channel blockers, beta blockers, and tricyclic antidepressant toxicity.
Yeah. But I think the value of lipid sink is questionable, but well, you may use
Probable
it if
benefit.
probable. And the role of glucagon, as you said, the dose is in beta blocker poisoning, but maybe if you've used all and still you possibly could use, that's where it is. Okay. And you do expect hypokalemia if at all, but in this particular patient had a hyperkalemia which is unexplainable. Anyway, so I think we did cover all the gamuts of a calcium channel blocker poisoning. So I'll just give it back to Dr. Sandeep. Dr. Sandeep?
It's a fantastic case. Fantastic case, Rohita, and what is the other name?
Ruhi.
Ruhi, yeah, fantastic case. And who was your consultant? Who was your consultant who looked after this patient? Kudos to that person also. Who was with you?
Misra sir, Dr. Shiva sir and Karthik sir.
Yeah, fantastic, fantastic. Yeah, Shashidhar, over to you.
Venkat sir. Okay. Thank you, sir. I think there are no questions from the audience also. Only few comments are there. That also for the questions which we have discussed already.
Sasi, you can conclude. I'm on the line. It took time, but you can conclude. A wonderful session by both of you. Extensively discussed. Thank you for your time. It is always an honor to be a part of it.
Our pleasure.
Yeah. Thank you, Sanjith sir, and thank you, Dedeepiya sir, for giving your time and sharing your knowledge with all the students across the India. Even at the end of 1.5 hours, we have more than 120 participants for the discussion. By tomorrow, I think it will cross more than 2,000 viewers. Thank you, Dr. Rohita and Dr. Ruhi, for bringing a good case for discussion. Thank you, everyone. We'll conclude the session.
Thank you.
Thank you, sir.
Bye.